Greetings, I'm Dr. Nancy Brock, and this is one of a series of practice tip presentations regarding small animal anesthesia. The topic of today's brief presentation is what to do about apnea at induction. So, your patient has gone apneic at induction, you've observed this, and you're going to correct the situation and accept that this is not some adverse drug reaction that you're having to deal with. The number one correction really is quite simple. Every anesthesia machine has a reservoir bag on it. And if you partially close the pop-off valve and squeeze the reservoir bag, you'll be able to expand the chest and deliver a breath. And therefore, you're in control of the situation. It is not a crisis. The idea here is to temporarily take over breathing for the patient until it figures out to breathe on its own. And that oftentimes is less than 5 minutes, certainly less than 10. And during that period of time, you're going to give no more than, say, 3 breaths a minute, because your goal really is to make sure that there's oxygen being delivered, that the CO2 is being evacuated, and that you are beginning to get isoflurane to the brain, because you have the vaporizer on at this point, and you are starting to deliver isoflurane to the patient so that as your induction drugs wear off, there's enough isoflurane background to keep the patient asleep. That's where the rate comes from, 3 breaths a minute. And then if you have a capnograph, the goal when you're giving the breath is to keep the CO2 on the high side, because you want the CO2 to register with the brain high enough that the brain says, oh, I have to breathe. And in this slide, I've got an image of a capnograph showing an end tidal CO2 of about 59. And so 60 is this number that's easy to keep in your head, whereby that's your goal when you're giving a breath to the patient and you're waiting for the patient to figure things out on its own and start to breathe on its own. Don't lower the CO2 too far, because then the patient will just decide, well, my CO2 is low, I don't have to breathe on my own, and you'll be ventilating the patient throughout the procedure, which in itself is not bad. I jokingly say to people it's a good way to keep the anesthetist awake. But in fact, if you want the patient to breathe on its own, allow the CO2 to build high enough that the patient's brain will trigger the patient to start to breathe on its own. So what's the definition of a small breath? I have a picture here of couple of breathing circuits that have pressure manometers on them. And so quantitatively, my definition of a small breath is to squeeze the reservoir bag and have the manometer needle go up to about 10 centimeters of water. And you should be able to see a little bit of chest movement with that small breath, and that's really all you're trying to achieve until the patient starts to breathe on its own. You can choose whatever vaporizer dial setting you think is appropriate. And in a separate practice tip video, we speak a little bit about depth of anesthesia.
I hope you found this video helpful. Please hit the like button and subscribe to our channel.